Richard Wender is the featured speaker, and I'm delighted to introduce him to you, and I'm looking forward to his lecture. So Richard actually has a very interesting background. After finishing college at Princeton, he got his medical degree at the Perelman School at the University of Pennsylvania School of Medicine, and then spent his entire medical career as a family practitioner at Jefferson Kimmel Medical School now, as it's called. And he had an illustrious career there as a generalist, rising through the ranks and eventually becoming chairman of the Department of Family Medicine. Interestingly, he has a lot of academic medical interests. One of them that I realize is that he was one of the first people to put together a comprehensive medical home in the Commonwealth of Pennsylvania and had it renewed. He has a passionate interest in not just colon cancer, but also cancer screening at large. And as a matter of fact, he was the first president of the American Cancer Society that was a general clinician. In 2013, after spending many years as a family practitioner and serving the American Cancer Society, which, as you know, is headquartered here in Atlanta, he was named the first ever Cancer Chief Control Officer. And he just reiterated to me that he still lives in the main line in Philadelphia and commutes back and forth and has a group of about 1,000 people that help him regionally to continue prevention and early detection of cancer. I think that his work is quite outstanding, and I think additionally his perspective is that of a generalist, which I think is really very important for all of you. Some of the comments we made, I think hopefully he will bring out about where we live in such a large state and what disparities that we face as physicians. So there's a lot more I could tell you about Richard, but I welcome him, and it's delightful to have him come to the podium. Thank you for coming, Richard.
Thanks, Frank. Thanks so much. You know, I really like that introduction. I thought you boiled down my... if you would travel with me and introduce me at every talk, I think I would love that. So really delighted to be here, have good friends and colleagues who are either at Emory now or have come through the Emory system, and particularly delighted to be at Internal Medicine Grand Rounds, but part of the Division of Gastrointestinal Disease. It's a great link because that's what it will take to achieve this very bold goal of achieving 80% colon cancer screening rates in the nation. So let me tell you a little bit about the 80% campaign. This was launched, a big kind of driver of this was the Assistant Secretary for Health at the time, Dr. Howard Koh. The CDC and the American Cancer Society for 20 years have funded an organization of organizations called the National Colorectal Cancer Roundtable, of which I've been the chair since about early 2013. And in late 2013, we took advantage of this convergence of a number of events, including the expansion of health care through the Affordable Care Act, to say this is the moment to challenge the country to achieve an 80% colon cancer screening rates, and we picked a 5-year interval range till the end of 2018. One of the reasons this was such a critical moment is that we had been making a lot of progress. We were not starting from scratch. This is the steady mortality decline decade after decade, 3%, 11%, 15%, and 25% in the last full decade. And when you realize that we took more polyps out in that decade than in any preceding decade, we've already banked a further reduction in colorectal cancer mortality. You can count on it. And that's the right time to launch a goal. You don't want to launch a goal when you haven't even built the national capacity to do something. Here's where we stand, and I'll particularly point out Georgia. It's in the second to worst tier for prevalence of colorectal cancer. There's Georgia for those who flunked geography. And here we are again in Georgia, and in the middle tier for incidence rates from 2008 to 2012. And here we are again in the middle tier for mortality rates. A lot of this tends to relate to the age and distribution, immigration percentage, because the rates are different among different populations. So how are we doing with screening rates since we launched this campaign? We started in 2012. We used the Behavioral Risk Factor Surveillance Survey as kind of our report card. And as I'll show you in a moment, rates were on a plateau. And we've gotten off that plateau. We were a little disappointed to only get up 1% in the 2014 to 2016 interval. But I'm thrilled to tell you that when you break it down state by state and by subpopulation, take a look at the Medicare population in BRFSS that just came out. Medicare, which everyone has insurance, most people have a regular source of care, most people access care. Anyone want to guess where the Medicare rates are for colorectal cancer screening? 78.6%. So we can achieve this in Medicare, and I just met with Medicare last week to try to knock out some of the policy barriers, which you are very familiar with. The recoding of screening to diagnostic. We just met with them trying to solve that very difficult problem, which if we have time, I'll be happy to touch on. But when you break down the BRFSS, there is some good news and some bad news. Some states showed marked increases in screening rates, while some actually lost ground. So take a deep breath for the next slide. Georgia's screening rates went down 4%. It was the largest drop in the country. So think about that. Who launched this campaign? The CDC. They're your neighbor. In fact, my GPS kept trying to tell me to drive into the CDC. Who else launched this campaign? The American Cancer Society, right downtown. And here we are together in Georgia. We saw the largest drop. Despite, oh, by the way, the founder, the person who suggested the idea of this 80% goal is a doctor named Jim Hotz, who works in Albany, Georgia. So this is a Georgia-centric campaign, but we're not doing a very good job. Well, why is that? Because you show me the states that have higher uninsurance rates. Show me states that particularly heavy rural, large income disparity, and that's where you'll see the barriers to screening. Does that mean that it is not actionable? No, it is actionable. There are some states who are doing a much better job than Georgia, but it will demand leadership. HEDIS is the commercial plan. These are not Medicaid or not Medicaid. It's not uninsured. Everybody here has insurance. And once again, you see knocking it out the park, particularly in the Medicare PPO rates, really good. This is HEDIS. This is not the behavioral risk factor. That's why the numbers are a little different. But we are concerned about these commercial payers where we really have not seen a big budge. So this is that 50 to 64-year-old group who has regular commercial insurance. But it's hard to reach the kind of average primary care clinician who, even if they're employed by a system, may not feel terribly integrated into that system and may not be a part of a large network who's putting in the state-of-the-art quality improvement measures or feel as much incentive to do this. Now, these are the measures in the federally qualified health centers, the UDS. And 2012 was the first year they were required to report colon cancer screening. This is where the American Cancer Society staff has put most of our work. And we're delighted with a 10% jump. Now, remember, the FQHCs, this is where most of the uninsured and medical assistance patients get, particularly the uninsured, get their care in FQHCs. And they also have a very high percent of medical assistance. So a lot of barriers, but a 10% jump in 4 years, because 2012 was the baseline year, is terrific. And finally, probably the most accurate measure is the National Health Interview Survey. And take a look at what happened between 2010 and 2013. And you see there was no movement at all in colon cancer screening rates. And this report came out after we had launched the 80 by 18. And I tell the story that I was fantasizing that, well, colon cancer screening rates were just on the rise. We'll just ride the momentum right to 80%. And then we saw the NHIS data. We said, oh, my God, we launched 80 by 18 just as rates had plateaued. So after being a little disappointed, I said, you know what? What better time to launch a big campaign when we've reached the people who are easy to reach? Now we have to go over the people, after the people who do not wake up in the morning and say, today is the day I want to be screened for colon cancer. You know, so we already got those people. So we have to get the folks who don't think it's such a wonderful idea. And the good news is we saw that rise in every subpopulation: white, non-Hispanic, black, Asian, and Hispanic. Now, the rates are still lower in the Asian and Hispanic group, but they did get off the plateau. In the case of Hispanics, they'd actually been dropping. This represents an additional 3.8 million people who'd been screened, and even if we didn't get the rates any higher, by 2030, that would translate to just under 40,000 cases of colon cancer prevented and 37,200 deaths from colorectal cancer prevented, all by 2030. So let me tell you a little bit about where we are in 80 by 18 and how we're going to get there. So one of the most important lessons is that both colonoscopy and stool blood testing are critical strategies. We will not, and no system is achieving 80% relying on colonoscopy alone. The best we've seen is the state of Minnesota, where almost all the screening is done at colonoscopy, and they are at 70%, but no system is at 80% with colonoscopy alone. So both are critical. Why are they both so critical? Well, let's talk about colonoscopy first. So we have to make high-quality colonoscopy as widely available as possible. There's no matter how you screen, whether you go right to colonoscopy or if you do another test first, if that test is abnormal, you have to get colonoscopy. There is no successful screening without it. And most of the rise in screening that I showed you earlier was because we've been doing more colonoscopies. If you do not represent that this is the original Captain Kirk, who Dr. McCoy did that tricorder thing and said, I think you have a polyp, but he still is going reluctantly. So if you just look at it very practically, I always say the more people we can get to have a colonoscopy, the better. Because imagine 1,000 unscreened people in 2015. Let's say 200 of them have a colonoscopy in 2016. Those 200 are now up to date for the next 10 years, or depending on what you found, at least for the next 5 or 3. So you now can go after the next 200 people, and you keep that rate climbing. If you use a fecal immunochemical test, it's only up to date for a year. That means that the 200 or 300 or 400 you reached in 2015, you need to reach again in 2016. And if you want the rate to go up, you have to add 100 more people. So this demands a much more comprehensive system of screening, whereas colonoscopy, you have a window in which to recommend that. But if we're going to, one of the real goals of the 80 by 18 campaign is not just to count screenings, but to improve quality. Not all colonoscopies are created equal. The GI professionals know that. That's got a lot of attention, but not all of the generalists are aware of how variable colonoscopy screening is. There are 3 components of quality: screening the right patients at the right intervals. 2, maximizing bowel prep quality and patient show rates. And 3, monitoring adenoma detection rate, and that is the most important of all. So let me talk to you a little bit about the right patients at the right interval. There's a lot of confusion about this, but this is the best set of guidelines out there. This was done by the Multi-Society GI Task Force. So if you have a first-degree relative, one relative over age 60, or 2 second-degree relatives, the only change in the guidelines is to begin screening at a younger age 40. Doesn't matter which method of screening you use, you should just begin 40 and do usual screening. But if the relative was under 60, or there are 2 or more first-degree relatives, then we recommend only colonoscopy and that it be done every 5 years starting at 40, or even younger depending on the age of the relatives. How about surveillance? This is one of the most common errors we're seeing around the country. We're doing both too little colonoscopy, where we're missing people, and we're doing too much colonoscopy in people who don't need such aggressive surveillance. If all that was found is one small adenoma, they do not need to be back at 3 years. In fact, a very small diminutive adenoma, probably 10-year interval, is fine, unless they had a family history. Now, some patients do need to come more often. Those are the people with multiple adenomas or large adenoma, villus adenoma, dysplasia. These people do need colonoscopy, and they need to be back at 3 years, 3-year intervals. We even have guidelines, and I realize you're not going to memorize all this. The slides are certainly happy to make available for you. In fact, you have them on your system here. But we even have guidelines now that, depending on what the first surveillance colonoscopy showed, if the first surveillance in a low-risk adenoma patient was normal, you can go back to a 10-year interval. They do not need to stay on 5-year intervals for life. Why is this so important? Because colonoscopy is an expensive and limited resource. And we need to be dedicating our colonoscopy resources in the most effective way that we can. How about better show rates and better bowel preps? The answer here is absolutely proven. It's unquestionable. It's incontrovertible. Lynn Butterly, New Hampshire, and now other investigators have shown that you can achieve a perfect show rate with perfect bowel prep with colonoscopy navigation. This is not navigation provided in the primary care setting. This is provided by the endoscopy center itself, whoever's responsible for that. This is published, available in the literature, and will show you. And if you go on our website, the NCCRT website, we have a guide to colonoscopy navigation, how it's done. And Lynn Butterly, and this is entirely for her uninsured population. This is not a highly educated, high-income population, has achieved perfect show, perfect prep in over 2,000 patients, all through navigation. And it's also been proven to be it pays for itself because you don't have missed appointments and everybody shows up well prepared. All right, now let's talk about adenoma detection rate. That's the most important quality measure of all. And I'll challenge you with this question. Have any of you ever heard the story? You know, I had a really fast-moving colon cancer, really aggressive. Well, what do you mean? Well, I had a normal colonoscopy. 2 years later, I had a huge cancer with mets. We now know that it's highly unlikely that they had a very aggressive cancer. It is far more likely that they had a missed advanced polyp or even a missed cancer. And, you know, for those of us in primary care like me, if you'd asked me 6-7 years ago, I would say, no, I just send them off to colonoscopy. It's all good. They know how to do this. I'm now much more discerning, and I'm not going to send my patients to someone who cannot tell me what their adenoma detection rate is. This is an expectation. So what is ADR? It's the percent of screening exams where at least one adenoma is detected. And as Frank knows, there's now guidelines coming out on what percentage where you should find more than one. But that's the definition. And ideally should be more than 30% in men and more than 20% in women. Why do those numbers matter? This is really stunning. So here is a series of patients looking at interval cancer development between colonoscopies. And if you look at patients who were screened by centers who achieved an ADR greater than 20%, the yellow line is actually the data point. There are no interval cancers for over 4 years. And then there's one interval cancer, and that's with an ADR over 20%. Look at the groups achieving an ADR under 11%. Not that big a difference. The first interval cancer is seen at 6 months. At 6 months. So these cancers were missed. These were missed. And you can see that by 5 years out, it's quite substantial. And how variable is this? This is from Kaiser Permanente. ADRs in their 136 gastroenterologists range from 7.4% to 52.5%. So all of us need to be looking at this. How do you improve quality? You guys know that. You have to commit to this. You need a registry that monitors show rate, prep quality, cecal intubation rates, and ADR. And there are registries available. The Standardized Colonoscopy Reporting and Data System. There's an article called CORADS is one registry you can use. Use your own registry. But you need to be able to measure and report this. So that's colonoscopy. But even if you do colonoscopy as your primary choice, and I still do a little bit of practice up in Philadelphia, tidy about, we had a lot of colonoscopy available to us, so that was our primary approach, was we recommended colonoscopy. But if the patient hesitated, not refused, not didn't show, they hesitated. By the way, a definition of hesitation is give me the phone number and I'll schedule it. You know what that means, by the way? That means give me the phone number so I can leave. That's what that really means. About under half of the people who are given a phone number to schedule that test actually schedule it. So we don't let anybody leave without a scheduled appointment, or they get a stool blood test. And then they can change their mind if they want to go to a colonoscopy later. So you must be able to offer stool blood testing and have confidence in it. If we view, one of the most important things that the 80 by 18 campaign has done is it has increased national confidence in stool blood testing. And we now have the major GI organizations, all who have endorsed the idea that there are first-line tests at the same level of colonoscopy. The latest guideline that come out put both fecal immunochemical test and colonoscopy as first-line tests. Now, the key with FIT, as I said earlier, is it has to be provided every year, only for average-risk patients, as I showed you. You have to ensure follow-up colonoscopy. Why is it so important? Well, it's extraordinarily less expensive. It can be offered by any member of the team, no bowel prep. Privacy of your own home, we've shown that's very important. There are many patients who just want to do stuff at home. No time off from work, non-invasive, no risk. But critically, if a single positive is found, colonoscopy is critical. Here's a randomized trial from San Francisco in an FQHC, randomly assigned to be invited to colonoscopy versus stool blood testing. Only a third of the patients did the colonoscopy. 2/3 did the stool blood test. So we need both to get there. Colonoscopy is critical, and I never give a patient a FIT without saying, if this is positive, you will need a colonoscopy. And I get the patient's agreement to that before I give it. If they say, nothing you do will get me to have a colonoscopy, then you better address that question before you start being happy that you gave them a stool blood test. They have to agree to that. I think we finally, after 20 years, are starting to see the disappearance of the guaiac, the classic Hemoccult guaiac test for screening. Most people have switched to the fecal immunochemical test. Just very simply, they're better tests. They're more specific. They're easier to do. They don't require any sort of change in diet. They're based on the immunochemical detection of human hemoglobin as an indicator of blood. If you draw 2 C's of your blood and you drink it, then get counseling. You should not be doing that. But if you did that, that was humor. I got one smile. Thank you. One smile. So, if you do that, a fecal immunochemical test will test negative because it's digested in the upper GI tract, whereas a guaiac test, as you all know, because we teach you this in medical school, if you have a nosebleed, that you swallow, you're going to have a positive guaiac test. So the FITs are better. And this is just one of many studies. It's from the Netherlands that just, to me, it kind of just settles the issue. FITs had a higher return rate, 60% versus 47%. They're easier to do. They had a higher positivity rate. They found 3 times more polyps. They found 4 times more advanced adenomas and over double the numbers of cancers. With a single sample FIT, only on 1 bowel movement as opposed to the 3. One important point, and by the way, we found this very commonly in the primary care physicians here in Georgia. About 1/5 of them are still telling us that they're screening for colon cancer with a rectal exam and checking the blood on the end of the glove, which has never been, and I don't anticipate will ever be, a recommended screening test. No evidence that any type of stool blood testing is sufficiently sensitive when done on a rectal exam. So we don't try to talk doctors out of doing what they believe to be right. We just say, if you feel a patient needs a rectal exam, you do it. But just realize you've not screened the patient for colon cancer. They either need a FIT done at home, they need a colonoscopy, or one of the new tests. Speaking of the new tests, there are now a menu of options. There's FIT DNA, only one brand name for that, Cologuard, and if you've never heard of it, you need to be watching more television instead of studying and reading the journals because they're advertising extensively. CT colonography, which also goes by the name of so-called virtual colonoscopy, and Septin-9, which is an FDA-approved blood test, but it's not clearly recommended by any guideline group just yet. So let's just talk about, I opted not to talk about these now just for time, but if you have questions, I'll be happy to comment a little bit more about FIT DNA. It's more sensitive than FIT, but it's a $500 test as opposed to a $20 test. It's in a number of analyses, it's graded out as the least cost-effective of the approaches to screening. So, but for a patient who has good insurance, who only wants to do something non-invasive every 3 years, it might be the best option. Now, some of you may have seen these 2 reports that we published at the American Cancer Society this year. One, the more recent one, is showing these rising mortality rates in younger patients. And interestingly, this was only seen to date in the white population, not the black population. And it starts in the late 40s and keeps going up into the 50s. Sorry, I'd asked that, not sure this is the most recent version, because I did ask that we add the slide showing the rising incidence as well of colon cancer, and particularly rectal cancer, 4 times higher in the birth cohorts born recently compared to the birth cohorts 30 or 40 years ago. So both rectal and colon cancer are on the rise. We don't know the reason, particularly rectal cancer. So let's talk about 80 by 18 and where we are with the campaign. So these are all of our strategies. 1 is promoting the campaign. 2 is primary care, state by state, healthcare plans, difficult but critically important, hospitals and cancer centers. I will dwell on that. Large employers and CEOs, we've had some tremendous success. AT&T, for example, the entire company is working with us, and we have other very large employers. Tailored messaging, I'll tell you a little bit more about that. Overcoming the financial barriers, using all these strategies together, and working hard. So a little bit about the campaign. I'm thrilled to report that the world loves a good goal, and as public health stories, this one works really well. Organizations are eager to pull something together and do something really impactful. We had an idea in 2013 that maybe we could get 50 of the top organizations to sign this pledge, saying that they're going to work hard to make sure everybody gets screened for colorectal cancer. This is the C5 Coalition in New York City. Well, I'm thrilled to report that we did pass up the 50 organizations. In fact, we have passed up 1,500 organizations who've signed the 80 by 18 pledge and still going. And these are many huge organizations. You see the American College of Obstetricians and Gynecologists, Pennsylvania Department of Health, American Academy of Family Physicians, and many, many others. We have pledges from all 50 states, Washington, D.C., Guam, and Puerto Rico. I'm thrilled to Doug Lowy, who leads NCI, and Bob Croyle came to visit me here in Atlanta and learned about the 80 by 18 campaign. Well, they knew about it. And in fact, 80 by 18 is included in the Moonshot Report from the Biden initiative. This was our March event in New York City at the Hard Rock Cafe, hosted by Katie Couric, who's been a real champion for us. And anybody know who that other person is? Anyone? Amazing. Not a soul. That is incorrect. I would have called you out if you'd said it right. It is correct. It is the other guy from the show. This is Luke Perry from 90210. And it's a generational thing. If you're in my generation, nothing. That's nothing for me. And if you're too young, nothing. You are in the middle, and you knew who he was. So, but I will tell you, Luke Perry's been a tremendous champion of ours. He's still working with us very closely. Here where we were on the Hard Rock Cafe. Here's an event in Camden, New Jersey. I showed this one because this pledge signing includes 5 mayors from cities around New Jersey. Here, this is the mayor of Buffalo. That's the mayor right there who signed with us. And this, I'm told that this was the first event in the history of Buffalo where every healthcare player came together to do something because we spent too much time competing. Here's Little Rock, Arkansas, that went blue, and their mayor became, I think, the 3rd mayor to sign the pledge. Here's Columbus, Ohio, glowed blue for the night, which, if you know anything at all about college football, for Ohio State to go blue, anybody get that? Yeah, good. Is not good. That's a big sacrifice for them. So one of my favorites is 80 by 18 shining up in the Health Care Service Corporation building in Chicago, Illinois. Even Niagara Falls has gone blue for us. So is 80% achievable? It is. 33 Medicare Advantage plans, 28 community health centers who take care of the uninsured and medical assistants have achieved 80% screening rates. It can be done. 10 big commercial health plans, 3 medical practices and health systems are reporting it. It's a total of 76, I think, who've achieved it. The second thing I want to mention is primary care because the basics of screening have not changed. If you don't have health insurance, it's a lot more difficult. So the more people that we can get to have insurance, the better. And we are seeing an increasing gap between the Medicaid expansion states and those that did not expand Medicaid. ACS published on that in cervix cancer. incidence and mortality just recently, advanced abnormalities on pap smear. We're seeing a widening health gap. Everyone needs a primary care clinician, a trusted source of primary care. The single biggest determinant of whether or not somebody's screened or not is whether their primary care clinician told them to be screened. But it sounds so easy, and I can't tell you how many meetings I went to over the years where people would say, if their primary care doc would just tell them to be screened, this would all be taken care of. But guess what? The diabetes meeting next door was saying the exact same thing. If just the primary and the asthma meeting was saying the same thing, and the injury prevention meeting were saying the same thing. This demands a systematic approach. You cannot put this all on the hands of a single clinician. You need a screening policy. How are we going to screen our patients? I mentioned our screening policy in Philadelphia. Colonoscopy was recommended primarily, but for the patient who hesitated, they got an FIT. There's good data now that if you give the patient a choice, and I can't tell you how many patients around the country are being said, you want a colonoscopy? I recommend no, don't want it. They're going, okay. Meanwhile, there's a $20 test that you could hand them that they would do. So the options and choice has been proven to be effective. Everybody who's achieving 80 by 18 at 80% rate has had a champion. The most dramatic, I think I have an example. I think I have the example later. If I don't, I'll mention it. If you don't have a champion in the system, you're not going to get there. So if Emory is interested in improving their screening rates, or even learning what their screening rates really are, not so easy for hospitals, you need to identify somebody who's willing to be the champion for this, and they need the support of leadership. There's lots of evidence-based ideas like Flu Fit, doing flu clinics where you link with assessing screening status and giving a fit. We've funded several links of care program where you take a federally qualified health center and link them with a colonoscopy network. This is the biggest barrier, is building that colonoscopy network. Lack of access to colonoscopy remains our biggest barrier to getting patients screened, and we've published through the NCCRT on our website how to do that. So let me jump ahead to hospitals and cancer centers. So we do believe that hospitals and cancer centers can play a critical role in helping us get to that 80% goal, which we showed would prevent 270,000 cases and deaths from colon cancer if we can achieve that, all by 2030. That's 1 million deaths prevented by the turn of the century. So here are 5 steps that we recommend for hospital leadership. Recognizing and overcoming barriers to participation, and there are many. Champions that I already mentioned. We think a public commitment to achieving the goal really matters. The leaders up front signing a pledge saying we're going to put our resources to do it. You need an interdisciplinary team linking primary care, GI, pathology, anesthesiology, make sure the surgeons are on board, the hospital's on board, so that if you do find disease, it can be treated. And then implementing the 80 by 18 hospital strategic plan, which is on the NCCRT website. I want to take just a moment, though, and talk about the role of NCI-designated cancer centers. So one of the challenges we've had with 80 by 18 is really getting leadership from the NCI-designated cancer centers, which is exactly where you think the leadership should come from. So just 2 weeks ago, we convened a meeting in Washington. Bob Croyle from NCI, who leads the Population Health Division at NCI, Lisa Richardson, who leads the CDC Center for Cancer Prevention Control, and myself, under the auspices of the National Colorectal Cancer Roundtable, convened a meeting, and we brought together 5 of the most successful NCI-designated comp cancer centers who are doing a great job with colon cancer screening. It was Ohio State, MD Anderson, Thomas Jefferson, University of Pennsylvania. Somebody was there from, I believe, George Washington, who was doing a good job. So here were some of the recommendations that emerged from that meeting. Some of you may recall, but I suspect most of you do not, that all of the NCI-designated cancer centers in the country came together and issued a shared joint statement promoting HPV vaccination. They have not done the same thing for colorectal screening. So we would recommend that the comp cancer centers, my good friend, Dr. Wally Curran, we were chairs together up at Jefferson, who leads the center here, join together, and we will be following up to that to endorse this initiative. Second, all NCI-designated cancer centers have to define their catchment area. What population are we responsible for? Well, unfortunately, one of the biggest barriers we've had is that hospitals and cancer centers have defined this catchment area by, well, who are we taking care of? Who are our primary care clinicians taking care of? Rather than the geography that they care for, the 100-mile radius. That's a different story when you say our catchment area is this 100-mile radius. And what are we going to do to reach out to them? We believe that needs to be defined broadly. The centers that are doing well, the comp cancer centers doing well, have a distinct unit. They have a division or a center that's dedicated to prevention and screening. Dr. Ernie Hawk from MD Anderson, who leads their initiative there, was part of our meeting. That's obviously tongue-in-cheek to say nothing to it. This demands some resources and some leadership commitment. And then there are plenty of evidence-based interventions that can be introduced. So let me jump to tailored messages to reach the unscreened. So the American Cancer Society, about 2.5 years ago now, conducted market research in over 1,000 unscreened individuals. I love these two women. A colonoscopy with a friend, priceless. Anyway, great. And here's what our research showed. The number one barrier to screening, particularly in the pre-Medicare population, which I showed you is a real challenge for us, is I don't have health insurance, I'd not be able to afford the test, and I don't feel that it needs to be done. These are all actual quotes from people in the survey. So affordability was number one. Number two was just lack of understanding of screening. Screening has nothing to do at all with symptoms. In fact, if you have symptoms, you need a diagnostic workup. In fact, one of our lessons, if I may just move off the screening topic for 1 second, is one of our lessons from this rising incidence that we're seeing in young people is the disturbing number of patients who presented with symptoms, including rectal bleeding, but they were young, so they were told it's normal. It's normal. Please raise your hand if you have learned a normal cause of rectal bleeding. There is no such thing as normal rectal bleeding. Any patient with symptoms needs a full diagnostic evaluation at any age. That doesn't mean they need a colonoscopy. You just have to show where the bleeding is coming from so that you know the answer. So lack of symptoms was number two. A lack of a family history. Again, 80% of all colon cancer, there is no family history. That was three. This is number four. Some people thought it would have been higher up, but perceptions about the unpleasantness of the test is one of the barriers. This is an actual quote. I do not think it's a good idea to stick something where the sun don't shine. The yellow Gatorade I cannot stomach. Number five, my doctor didn't recommend it. We always see that as a barrier. And number six, I have other health issues that I'm worried about. Colon cancer is just not high on the list. Interestingly, number one among Black, African-American, and African-American individuals is that the doctor did not recommend it. So we then tested, and these are all tested messages, which would motivate action. And these were the ones that emerged, and you'll see how they address the barriers. There are several screening options available, including simple take-home options. Talk to your doctor about getting screened. Interestingly, when you tell people that colon cancer is the second leading cause of cancer deaths in the U.S., when men and women are combined, that is motivating. Emphasizing prevention. It can be prevented or detected early. We really should be very clear when we talk about screening that the most common outcome of a screen is not an early cancer. It is a polyp. And it's mainly effective through prevention, not chiefly by early detection of cancer. Or preventing colon cancer or finding it early doesn't have to be expensive. There are simple, affordable tests available. Get screened. Call your doctor today. So those were the tested messages. If you've never gone on our NCCRT website and you're interested in colon cancer screening, it's absolutely required. Every tool, this is just a small sample of them, for every audience is on that website. What insurers can do, what primary care physicians can do, what the 80 by 18 campaign is, hospitals, this communication guide. We now have a communication guide for Hispanic and Latinos, and we just published a new communication guide for Asian populations. Financial barriers persist. They are our major barriers I showed you to being screened. So that's why we think the federally qualified health centers and academic centers, because as you know, It's not just the FQHCs who are taking care of high percentage of low-income, uninsured medical assistants. They're being cared for by everywhere. And I do believe that the academic clinics and centers have an important role to play. So let me ask you this question. Do you think that to get to 80%, we should focus on working with primary care to implement population management? Or would you recommend that we focus on tailored messages directly to the unscreened? Or do you think it would be better to focus on working with hospitals or healthcare plans? And what I'll tell you, my punchline slide was omitted here. The truth is that there is no strategy that will get us to 80% except everything. This needs multiple strategies. These all need to be pursued. There is no single strategy. So we have to floor the accelerator, keep the pedal to the metal. We've made this commitment, and we need everyone to do it. So here's what we know so far. I'm being asked more and more, are we going to get there? We believe this is the most successful public health campaign of its type in history, getting people to do something that is inherently not very appealing and that is quite expensive with colonoscopy. We are making progress. We're doing great with the FQHCs. The data lags, so we won't get our final report card to 2020 or even 2021, but the first wave of indicators is encouraging, particularly in Medicare. So what will happen at the end of 2018, since we're getting near there? Our plan is to act urgently over the next 15 months, push as hard as we can, but we are right now conducting a listening campaign to all of our participants, all of our partners, and figuring out the best way to keep this 80% campaign going. So we're going to rebrand it. You'll see the 80% will remain, but you'll see 18 disappear. Since 80 by 18 in the year 19 will not be very motivating. So people will be discouraged. I've already missed the mark. So 80% will stay. We think that is the right number. 80% is a fascinating number in preventive health. It kind of looks like the number that almost every preventive intervention is able to get to if you put everything together. Now, I will tell you that the leaders in the country, Kaiser Permanente, Northern California, and their Medicare population, Medicare, is at 91% colon cancer screening. So if all the conditions line up right, you can get even beyond 80. But we think 80% is the right number. But we also realize that many organizations are just now hitting their stride, and there's no way that we plan to stop pushing screening for colon cancer. We're going to chart a post-2018 course to determine how best to leverage the capacity we've worked so hard to build and keep it going. As I like to say, we're going to go as fast as we can, as long as it takes to save lives and achieve something truly amazing. The goal is big, but so is the potential impact of this. We now know that if we achieve 80%, depending on how quickly we achieve it, we will prevent, this has been well modeled, over 1 million deaths from colon cancer by the turn of the century. This is quite certain because I've already shown you the progress we're making. Right now, colorectal cancer is the second leading cause of cancer-related death when you combine men and women, but there's absolutely no reason that it needs to be. And we feel very confident that working together, we can knock it far down the list. It is not beyond reality to think that colorectal cancer could be knocked as far as 5th, 6th, or even 7th as a cause of cancer if we can get screening rates up to 80% and keep them there. Thank you so much for inviting me. Look forward to our discussion.
So a couple things. One is to get to 80%, you do not have enough people doing colonoscopies to do that in the future. It's going to be a problem. Secondly is something that plays a role in this that has been a problem here, I find, and it probably occurs elsewhere, is inappropriate referrals for colonoscopy. So patients had a polyp taken out 2 years ago. It should be a 5-year follow-up. They're sent at 3 years. The other one is mixing screening tests we get often. So they had a colonoscopy 2 years ago that was normal. Their primary care physician gets a fit test. It's positive. Yeah. They send them again for another colonoscopy.
Yeah.
You cannot mix screening tests. Once you start the fit, you continue with fit. If they have a colonoscopy and it's 10 years, you wait 10 years. So that is a big problem to achieving this goal of 80%, is that there are many inappropriate colonoscopies being done that probably don't need to be done.
Yeah. Let me, all wonderful points. Let me address the first two, and then the more challenging one is, do we have enough endoscopy capacity? You could not be more correct. This, and, you know, we're working so hard to increase screening. It's hard then to start getting these other messages out. Like if a patient has had a colonoscopy that's normal, they are up to date. They need no screening. And we don't even know what you would do with a positive, you know, what is the appropriate response to a positive fit at 3 years or 4 years if you had a normal colonoscopy? So clearly the right answer is to not do it. In this environment, it's very difficult to ignore it, you know, once you've done it. So couldn't agree with you more. Your other point about this, you know, not being familiar with the surveillance guidelines, or putting people on a 3-year interval or even a 5-year interval and then keeping them on that for life, even though they had one polyp and now they've had 2 more normal colonoscopies, they're still at a 5-year interval. And both of these issues feed into your third question, is do we have enough endoscopy? I would agree with you. Lack of availability of affordable colonoscopy is our leading barrier to 80/18, particularly felt by the uninsured, low-income population. And a lot of the 80/18 campaign has been various strategies to help places overcome it, and there's some places who've done an amazing job. 2 points. One point is, if you are an FQHC in a rural outlet and you find one colonoscopist, one person who's willing to do your colonoscopies for you, it will last about 6 months. Then they will be overwhelmed, and they will drop out. So one of our recommendations, and we've had multiple communities who've done this, is and we have models that are published showing if you do a stool-based program, how many colonoscopies will be necessary. You can predict quite precisely how many colonoscopies each center will have to do. And if you approach them then with that, say, will you donate 1 colonoscopy per month? You'll be amazed. You can get everybody on board. Finally, the last big study of endoscopy capacity was conducted by the CDC, but it's rather old. And that study showed that we probably do have enough endoscopy capacity if we use all of the screening strategies. If it is a colonoscopy-only screening strategy, clearly we do not. But if we use them all, and obviously we will see enormous variability based on geography and insurance type. Yes?
I wanted to bring up the point. Here at Emory, we had about 150 doctors and nurses help with a book, which was called Your Body's Red Light Warning Signals, so people know what symptoms are life-threatening. You know, like if you have a headache, fever, and can't put your chin on your chest, most people do not know that's an emergency. So now that's a free app. It's just under red light warning signal. I think and they have undergraduate students have started a patient empowerment club. And I think patient empowerment is an extremely important thing. You know, you go to school from kindergarten to 12th grade, and you learn all sorts of stuff that if we took final exams in those classes, you might flunk out, calculus and so forth. But if you could teach things relating to health like this to 7th graders or 12th graders, then, and it became a part of education, I think you'd be able to advance a lot more rapidly.
Yeah, thank you. We've had an extraordinary engagement from particularly the survivor advocacy groups. They've really been on board with 80/18, and the reason I admire it so much is that many of these groups' core membership were people diagnosed at 35. So they would not have been helped by 80/18, but they're so passionate about it. But it's thank you for that. And we are trying to address all those strategies. So appreciate that. I'd be interested to see the app.
Hi, thank you. So my question, it kind of goes back to what Dr. Kalin was saying. You mentioned Kaiser has done a really
Yes.
good job, but they use the fit test.
They do.
As well, right?
Yes,
So that's
although
how
they've shifted quite a bit. So if you look at Kaiser Permanente Northern California, which is T.R. Levin's program, who probably was, when I say what does it mean to have a champion, I always say, look at T.R. Levin. He's been working this for 20 years. And now about 45% of their screening is colonoscopy primarily. So it used to be that they did sigmoidoscopy, then they went to FIT. Now it's a combination of FIT and colonoscopy.
And then my other question was, you mentioned tailored messaging. I know there's been some work at not only at looking at tailored messaging, but also tailored messaging based on where the person is in their decision-making process.
Yes.
Right? Has the CDC done any additional work on that?
Yeah, thanks. One quick word about the Kaiser system using stool testing. Just to show you what it likes when you have a truly integrated delivery system, which I realize is not quite what we work in with a single insurance type. If you go to a dermatology appointment at Kaiser Permanente, the receptionist sees your colon cancer screening status. And if you are not up to date, the receptionist at your dermatology appointments gives you your FIT test. And we have one of our champions is somebody who had a skin cancer, went to the dermatologist, got a FIT kit, positive, and he had colon cancer. Hasn't an early stage. So that's a true systems approach. And I'm sorry, your second comment was about the tailored messaging. Decision making, yes. It's not that much of the work's been done by CDC. It's been done more by the academic centers. And probably the best model that I'm familiar with is Ron Meyer's work. And I know it well because I was involved in it at Jefferson. And the way they've done it is they simply ask the patient. It's not a stages of change model. It's just they ask the patient, here are the choices. Which do you think you'd prefer? And then they navigate the patient towards that choice. That's it. So it's not a really in-depth, kind of like showing everything. The other place that's done a lot of work with this is University of North Carolina, Michael Pignoni. He's done a more detailed approach. And then the final is Paul Schroy at Boston University. But up in Boston, his biggest barrier is they could not convince the primary care clinicians that it was okay to do a FIT. They just said, it's got to be colonoscopy. So I think if we could all join together and saying the best test is the one that gets done, that's one of our mantras in the 80x18 world. First coined by Sidney Winnower, the father of all colon cancer screening, the best test is the one that gets done. Yes. Other questions? Oh, he's the mic guy.
We had a question from the VA. They ask, what fraction of GI practices have unacceptable or low adenoma detection rates? And if so, of those low rates, does that justify FIT testing more potentially?
Yeah. So first of all, a big shout out to the VA. The VA is one of those 10 large integrated health systems who has achieved an 80% colon cancer screening rates. And so believe me, when I was meeting with our friends at Medicare the other day, because there's competition at the federal level, so I said to the leaders of Medicare, I said, your colleagues at the Veterans Affairs are at 80%. I know you would want to be, because my advocacy partner said, let them know about the VA. But what Dr. Domowitz, who's the champion there, has found is two things. One is adenoma detection rate, and I don't know the answer for adenoma detection rates, but they are working very hard on adenoma detection rate. And if somebody emails me at richard.wender@cancer.org, I can hook them up with Dr. Domowitz, who can provide that data. But the second thing that they found, since they were relying to a great extent on FIT, on fecal immunochemical testing, is that a unacceptable percentage of positive FITs never got colonoscopy. And that's a common problem around the country. You're actually counted as having been screened if you have a FIT test, which I'm not sure is the right thing to do, but that's counted as having been screened, even if the colonoscopy was never done. And if you think about it, that's a disaster, because now you have somebody with positive FIT 20 times more likely to have an advanced polyp or cancer. they desperately need colonoscopy. So one of the big foci of the VA right now is getting everyone with a positive fit to have a colonoscopy. So, but if they email me, I can hook them up, and maybe Dr. Domowitz can fill them in.
From Grady, they're asking, are FIT tests proposed to reduce healthcare costs? Is that something that goes into the
Yeah, great question, and big shout out to all the other hospitals, and we have had a great partnership, particularly with Grady, for years, so thanks for being part of this. Yes, there have been a number of cost-effective analyses that have compared these different strategies, and FIT annually with a colonoscopy for positives does come out as the most affordable overall. But there is no question. When I said pick a policy for your practice, well, you have to take into account your insurance mix that you're caring for. So if you're caring for an uninsured population or high medical assistance, and your main screening strategy is to send everybody for colonoscopy, that's a mismatch. I mean, you're going to have to rely on stool testing. We have plenty of slides, by the way, on fits. If you've seen one fit, you've seen one fit. They're all different, but even the USPSTF called out a single company, and we do as well, and that's the Polymedco OC check. I think it's called OC fit. It's distributed by LabCorp. Is the most tested of all the fits, and it's done on a single sample. It's what's used at Kaiser Permanente. So if you put me to the wall and said, which one fit would you do? It would be the Polymedco product. And it's, for many of the population served in public institutions, a primary stool-based strategy is very sensible.